both ACB and then with Dr. presenting for drug interaction last week. So we're going to continue that conversation. Since we have had so much on oral regulation last week, we are going to focus more on mechanics of drug interaction.
That's fire.
And what do I actually do in clinic when it comes to drug interaction? So before I get started, I wanted to touch base and make sure, were there any questions from Dr. Keaty's lecture last week on warfarin? Here's something. I'm moving forward. So our objective for today, what I want us to be able to do, is definitely identify some of our major drug-drug interactions, specifically associated with DOAC therapy. And when I talk about identifying drug-drug interactions, I have highlighted and bolded and put into blue for you to try and make it very, very clear on which drugs I expect that you will memorize, know by heart, and on an exam be able to circle the answer to that question and move on. So anything that is bold blue is a class 1 interaction. It's a major no-no, absolutely don't do these in combination, and move on with life. Okay? So your class 1 recommendations are bold and in blue. It'll make more sense as we go, but you'll see them in the tables are bolded in blue. Bolded in blue, you must memorize.
Bolded in blue.
Okay? There's not that many, and they're big flags that interact with everything under the sun, including DOAC. So, bold blue equals memorize. Okay? So when we talk about drug-drug interactions with DOAC, we usually think of not much, and usually we market DOAC as not having drug interactions the same way that warfarin does. So last week, when Dr. Keaty was presenting, we could have spent another 3 hours talking about all the drug interactions with warfarin. She narrowed down her presentation to some of the most specific drug interactions with warfarin and big things we think about, but she had to cut out a lot of material from the material that she did cover. So with warfarin, endless drug interactions, and we don't typically think of that for DOAC, although, as we'll see today, I think the DOAC interactions are actually more complex and more intricate for DOAC than they are for warfarin, and not quite as straightforward. So although we market them as being a great option, I put pause on that a lot of times because of the intricacies of these drug interactions compared to our warfarin therapy. Okay, so we'll keep that in the back of our mind. That should also give you a hint to the type of questions that I'm going to ask on an exam, right? So we have our big bold blue where we're going to memorize, and then we have our others, which are this gray area. And what I want you to pick up from this lecture is how do we sort through that gray area, and how do we determine the clinical relevance of our drug interactions when they exist and they're not our big bold blue class 1 drug recommendation. Okay, so we're going to do that together in one of the cases. I'm going to sort through that. How do we do that? Next, what I want us to be able to think through is renal function, and then also food interactions. And I think I reversed those in the slide set. But anyway, we're going to talk about renal function especially. We've already talked about this with DOAC. We're going to talk about it some more tomorrow. But we are going to hit on it today and do a little bit of a comparison from one agent to the other. And then we're going to talk about food interactions and how that's different, especially with DOAC. All right. So here's our game plan for what the plan is for today. Like I mentioned, we're going to do drug-drug interactions first. So drug-drug interactions, we are going to talk about PGP primarily and CYP3A4, and then the combination of PGP and CYP3A4. And then we're going to talk about bleeding risk. Like I said, we're going to cover renal function, and then we're going to talk about do you do these agents with food, without food, and what if you have a high fat. So let's dive into drug interactions specifically and talk about our PGPs. So as I just mentioned, you have big bold blue. Big bold blue means that I'm going to memorize these for the exam, and I'm responsible for knowing that if it is a big bold blue, class 1 drug recommendations, that I'm not going to do that in combination with any of the DOACs. So what I want you to note for the PGP slide is that your big gold blues are with any of the DOACs. So it doesn't matter which one it is, we're not going to do a big gold blue with any of the DOACs. Okay, none. None of them. Okay? I made this list small and unreadable for a reason. The reason that this is small and unreadable for a reason is because I do not want you to memorize this whole list. The only ones I want you to memorize on this list is the ones that are bold and blue. The other piece that I want you to pull from this is that it's all the DOACs.
Just wait.
So big gold blues, all DOACs. Okay. Right. The other piece that you can pull from this slide is that I specifically did not list hepatitis C and HIV drugs on this list on purpose. The reason I, on purpose, did not list those drugs out for you is because anytime you have a hepatitis C or HIV drug, you look it up automatically, no questions asked. So every hep C drug, every HIV drug, just look it up for drug interactions regardless. Unless you're a specialist and you know it, good for you, then more power to you, don't look them up. But other than that, kind of like oncology is largely the same way. So oncology, HIV, hep C, we don't memorize, or I try my best not to memorize those drugs because every time I'm going to look it up. Okay? So if I give you a hep C HIV drug on the exam, the answer is I'm going to look it up. Okay? All right. So to be very clear, big, bold, blue on this list. I'm not going to review them because they are there for you. We have both PGP inducers or inhibitors. Okay? So knowing whether it's an inducer, an inhibitor, where it falls on the list, and the fact that it's a big, bold, blue. All of those. Okay? Then we're going to move to CYP3A4. So for CYP3A4, also on this list, I want you to memorize the big bold blues. You'll notice that if you flip from big bold blues on the PGP to big bold blues on the CYP3A4, they're mostly the same. So I mentioned hepatitis C, HIV, itraconazole, ketoconazole. Most of them are fairly similar, but there are a few that are different. The ones that are different and are only CYP3A4, those are no-goes with rivaroxaban and apixaban. So for our CYP3A4 interactions, big bold blues are no-goes with apixaban and rivaroxaban. Okay? And that's because our apixaban and rivaroxaban have clearance through CYP3A4. So if we're messing with, it goes to the CYP3A4 pathway, then we're going to have that drug interaction. Okay? Of note, dabigatran does not use the CYP3A4 pathway. So because dabigatran does not use the CYP3A pathway, it's fine with these CYP3A4 drugs, unless they're also PGP drugs, which we're going to cover today. Okay? So if it is a big bold blue on CYP3A4 only, then you can use dabigatran. You cannot use rivaroxaban or apixaban. All right, we're about to do combinations. So before I go to combinations, let me get a yes or no if we're very clear on PGP and CYP3A4 interactions with DOAC. Any questions from any of us satellite campuses? Any questions from Savannah? Okay. Moving forward then, you'll see that our next slide, excuse me, still getting over my cold, so if I cough in the microphone, I'm really sorry, I know that's annoying. So our final slide with our major drug interactions for DOAC then is the combination of SIP 3, 4, and PGPs. And obviously, because you have the PGP piece, these are no-go across the board. So if it's a combination, then it's a no-go to give that PGP component. Okay? So these are no-goes with our big bold blues, or no-goes with all of our agents on this slide as well. The only one that's different is your 384 on the previous slide. Okay? All right. So those are pretty much what we have to worry about for DOAC therapy. Of course, go for it.
On this slide, verapamil is big and bold, but it's not blue. Do we need to know that one?
I didn't include it on the other one, so no. I got bold, Kathy, I'm sorry.
Thank you.
Thank you for pointing that out. Verapamil is not a blue. Sorry about the bolding. I'll fix it and repost it so that we have a clear slide. All right. Okay, so we have some drugs that are PGP, we have some that are 3, 4, and then we have some that are a combination. Okay? Obviously, our combination ones are going to throw up a little bit more red flags than other ones, but it's something to consider. So what I want us to do is go through this gray area. I think that's the piece of DOAC that's most helpful, is how do we sort through the gray. So I have posted a few cases, and this is where we spend the majority of our time today together, is working through this case in particular. So what I want to do, we're all going to do something different, and we're going to see how this works. So in Athens, I want you to go into the student portal, the research center, and I want you to use Lexicon. Okay? So Athens, you are going to use Lexicon to look up the drug interaction. Okay? So Athens has Lexicon. Albany and Savannah, I want you to use Micromedics. So Albany and Savannah, I want you to use Micromedics to look up the drug interaction. So for Micromedics, I put the login and the password. I'll make it bigger in a second because I don't know if you can see that. So Albany and Savannah, I want you to use Micromedics to look up the drug interaction. And then finally in Augusta, I want you to use facts and comparison to look up the drug interaction in case 1. Okay, so everybody pull up case 1. Athens, you are going to use Lexicon. Augusta, you're going to use facts and comparisons. Savannah and Albany are going to use Micromedics. All right, I'm going to give you roughly 10 minutes. What I want you to do is go through the case and critically evaluate the drug interaction. Okay? And if you want to cheat and look at some of the other drug interaction checkers, I welcome you to cheat and use some of the other drug interaction checkers that the other campuses are using. Because what we're going to do is comparison on the answers between the 3 different resources. All right, so 10 minutes-ish, and then we're going to come back together. And I'm going to make this bigger for y'all. In Albany, can you read that? The Micromedics password?
Yeah, we can read it.
Okay, perfect.
If you're connected to this Wi-Fi, you can just type in like facts and comparisons or Lexicon too.
It will force redirect you to Lexicon. It will force redirect you to Lexicon, I think.
It does.
Oh.
I just kind of thought that it was. So we can access Lexicon without going through RX, but if you try facts, it just takes you to Lexicon, which I was just thinking that they were bought out or something.
Yeah,
Just educated
Y'all do not have to work independently if you don't want to, either.
We weren't.
Feel free to. Go try.
Yeah, I mean, I'm good. Decrease eliminated.
Kendall, don't you know we've changed our ways? We're paying attention in class now.
Who? Is that a thing I'm supposed to get?
That's the thing that you're supposed to be committed to, not sending memes.
You hearted it.
Huh?
You hearted it.
No adjustment necessary for Did you know today's World Pharmacist Day?
My brother sent me a message that said Happy Pharmacist Day and you're indispensable.
Wait, that's so
It was so cute. She said if you want cheap music, it's a relatively weak
This says that no precautions are necessary if patients receive critical oxygen.
This is saying that it's a major spirit.
This one says the U.S. official packaging label for Xarelto.
It's an invitation to the payers and a bunch of nerves to adopt the U.S. prescribing information warrants and moderate. This is not used unless it's stupid or not used to tourists. She said it's prepared reading.
All right, Savannah says they're done. Athens, do you think you're done? Can I get a heads up? Athens? Athens yet? Somebody said,
Yes, we're done.
Okay, Albany? Albany, did you have time?
Yes, ma'am, we're good.
Awesome, and Augusta? How about y'all?
We're good.
Awesome. All right, somebody in Athens present my patient to me. Athens. Somebody in Athens present the patient for me.
Tim is an 86-year-old male who presents to the outpatient clinic for acute bronchitis. The resident physician wants to start him on clarithromycin 500 BID for 7 days. Past medical history is significant for hypertension, type 2 diabetes, and AFib. He's currently on carvedilol, metformin, and rivaroxaban, and he has a creatinine clearance of about 55 mils per min.
Perfect. Good. All right. So my first question is about the risk rating for the drug interaction. So Athens, what drug interaction am I talking about specifically here?
Clarithromycin and rivaroxaban.
Perfect. All right. So and I told Athens that they were to use Lexicon, right? So what I want everybody to do is follow along with me so you can see these things. I know it's hard for you to see up on the screen, so I definitely encourage you, and if I'm going too quickly, let me know, but I encourage you to do it on your own computer. Here's why I specifically want you to do it on your own computer, because you guys have an exam. And when you have an exam, I'm going to, I promise you, ask a question very similar to this, where you're going to have to do something very much like this for the exam. So I encourage you to follow along and do this with me, all right? So Athens, you went to Lexicon. I assume you chose the drug interactions checker here at the top. Hopefully it doesn't expire by our exam date, but if it does, we'll rework the question. All right, so for our interaction, we put in clarithromycin, correct? See if I can spell today. And we put in rivaroxaban, correct? Good. All right, Athens, so tell me a little bit about what does Lexicon tell us about the risk rating for this particular interaction?
It's a class D.
Yeah, so we categorize it as class D. And more importantly, it's not a class X, right? Sorry, I'm on back. Let me switch. Sorry. I knew that didn't look right. Hang on a second. Let me pull up Lexi. Sorry guys, bear with me a second. So Athens was using Lexi, and they came up with a class D, okay? So notice on Lexicon, the way that Lexicon talks about their drug risk is they use the A, B, C, D, X categories. So of note, this interaction is a D interaction, according to Lexicon. Okay, Augusta, what about facts and comparisons? What did y'all find with the same question in facts and comparisons?
Moderate severity?
Moderate severity.
Yeah. So in facts and comparisons, they call it a moderate severity, or that kind of yellow little line there that says that it may cause some deterioration in the patient's clinical status, right? Savannah or Albany, tell me about micromedics and what did you find in micromedics? Albany, can you tell me about what you found in Micromedics?
It says it's a major interaction.
It's a major interaction, right? So you see how we have differences between our three different sources. So one of them says it's a D, one of them says it's major, which I would categorize as an X if I was in my head, although major is kind of both a combination most of the time of D and X's. And then we have another one that says moderate. So this is dramatically different between each of our three different resources. Okay, so I want you to note that there are differences. So this, this comes to a very important point in that when we look up drug interactions, when we have this gray area, it's important that you use more than one source. So never, ever, ever do I use only one source to look up a drug interaction. That's a way to get yourself and your patient in a lot of trouble and potentially do a lot of harm if you use only one source. So I typically will use at least two, and one of my usual go-tos is Micromedics because it's a little bit more comprehensive than the other databases. So I'm a little bit biased. I'll admit to that I use Micromedics a little bit more than I use the other resources, just because of the complexity of Micromedics. But either way, I definitely look at two, because Micromedics tends to freak out about everything. So then you need something to kind of balance that. But if you only use Lexi or only use FACS, you might not put the weight on the drug interaction that needs to be put on it, okay? So always use two resources. Okay, so let's dive into it a little bit more. How would you summarize the drug interaction that exists? So Athens, how does LexiComp summarize this drug interaction? What do they say about it?
Clarithromycin increases the concentration of rivaroxaban in the blood, which will increase bleeding risk, and it's especially unsafe with the impaired renal function.
Fabulous, good. How about facts and comparisons? How do they summarize it? Augusta?
Plasma concentrations and pharmacological effects of rivaroxaban may be increased by clarithromycin.
Good. And then here in Savannah, what does Micromedics say?
May result in increased rivaroxaban exposure.
Right. So they pretty much all say the exact same thing when it comes to the summary. Nothing was different about what we just said. It increases the concentration, increases the bleed risk. That's pretty much across the board. So our warnings may be different, but our message is largely the same. Okay? So just looking at the letter or the symbol that they give you for the drug interaction is not enough. You have to actually dive in and see what it actually says. There's another thing that I want to note, which might be difficult because it's not letting me use FACS and Lexi at the same time. But if you look at this summary, then over here it says severity major, and reliability rating as fair. If you go to FACS and comparisons, let me see if I can get it to let me into FACS. Oh, this is annoying. Sorry guys, my home computer wants me to do both at the same time. But this one doesn't, so we'll just kind of deal with it today. Alright, if you go into FACS and comparisons, they also have this table at the top. So it says severity level, documentation level, and it also gives you an onset. So if you look at the difference between LexiComp and FACS and comparisons, our severity level was different, right? In FACS and comparisons, it said major. Here it says moderate, okay? In our documentation level, it's relatively the same, suspected and fair. It's kind of saying the same thing. And then the onset, it says here is rapid, but Lexi didn't give us an onset. right? There's nothing in Lexi that gives us an onset necessarily. Okay, so there are definitely differences there. And then when we go to micromedics, and we click on the micromedics recommendation, it says that the onset is not specified. It says severity is major. Okay, so again, there are some differences in the way that the drug interaction checkers report this information to you. All right, so then the next question is, what is your recommendation to the resident physician? What do you want to do for this particular patient?
Well, at least with micromedics, we can look at the data and see for the studies ourselves if it's relevant or not,
Okay,
and then make a clinical decision.
I like that. So you are in, where are you at? Albany?
Well, I'm in Athens, but I use micromedics a lot, and I know how it works.
Okay, cool. Tell me what micromedics talks to me about the data. Then we'll skip question 3. You say you want to go to question 4. I'm okay with that. What's my data that's there? What does it say? Tell me what the limit says. They're given interaction data.
I don't know why he knows what to do o'clock.
Okay, now I'm talking about the section right here. So for people with micromedics, we click on the interaction, and this is the window that pops up for the interaction. If you move down, there's a section here that says literature. Okay, so now I'm really glad we're going through this. Perfect. So for each of our drug interaction checkers, there is a literature section. So this literature section tells us where are they getting the information to say that there is an interaction. So in other words, what I'm looking for in this literature section is a few different things. I could be looking for, is there a PK/PD study that's giving me this information, which is more theoretical? Or is there a patient case that's telling me about this information, which gives me a little bit more data, at least I've actually seen it in real patients? Or there could be a randomized control type trial that would be even more evidence to say this actually does exist, this is a known problem, you should absolutely avoid this situation. Okay? So that's why it's important to not just look at the summary. Yes, we know it's a problem, but now we're trying to figure out, is it a problem for our specific patient, and how do we know that? We look at the literature. Okay, we look at the data that exists to give us that recommendation. So for micromedics, we go to this literature section, and it says, during a randomized 2-way crossover study, co-administration of clarithromycin and rivaroxaban resulted in increases of rivaroxaban, AUC, and Cmax. Healthy patients received a single dose of it after 4 days of pre-treatment with clarithromycin twice a day, and concurrent use increased the rivaroxaban AUC and the Cmax, and in addition, co-administration decreased the rivaroxaban mean plasma clearance by 35%. Okay. So what we're finding here is they did a PK/PD study, right? That little literature section tells me that they did a PK/PD study, and they looked at the effect of the rivaroxaban concentrations in the blood in patients who are taking these concomitantly. What this doesn't say is that they did a randomized control trial and 50% of the patients bleed, right? It does not say that. It does not say that when we study this in patients who are actually sick patients, who is the target population that we're using this combination of drugs for, that patients bled. It's not saying that we have a case report that suggests that patients bled. It's not saying that we've ever seen a patient bleed with this combination, right? It's saying theoretically in a PK/PD study, concentrations were different. Okay? All right, let's go to LexiComp, see what LexiComp says. Same thing with LexiComp, except for LexiComp, it's usually in this discussion section. So if you're on LexiComp, typically, sometimes you'll get it in the patient management, but most of the time the data, the actual literature, you'll see in the discussion section. So in the discussion section is where you see the literature, and again, they quote that PKPD type of information in that kind of middle paragraph. Okay? The other thing that LexiComp does is go on a little bit more to say, maybe we don't have all the evidence for clarithromycin, but we do have a little bit of evidence for erythromycin. And because clarithromycin and erythromycin have relatively similar clearance mechanisms, then maybe we can extrapolate the data from erythromycin to clarithromycin. See this bottom paragraph? Talks about erythromycin as well. Okay? So now we have even a little bit more evidence to say not only does it exist in one, but it might exist in the other. And then I don't know if it'll let me go with that. Say it one more time.
About the top paragraph under Lexi about the retrospective study.
Thank you. I missed that piece. Thank you. So yeah, so what we said earlier with micromedics is that, thank you for catching me. We said that there was not information in patients, right? That was presented in micromedics in that literature piece. But here, we do have some evidence in patients, right? So this is a large retrospective study of Taiwanese, lots of Taiwanese patients who have non-valvular AFib, which is what our patient has, and they're treated with rivaroxaban, which is what our patient is treated with, or another non-vitamin K antagonist, so either dabigatran or apixaban, and clarithromycin or erythromycin, and it was associated with a 40% decrease in the incident rate ratio for major bleeding. And then they also note that several other combinations examined in the cohort yielded findings contrary to what would be expected based on available pharmacokinetic interaction data, pharmacology, blah, blah, blah. And then the precise clinical meaning of these findings is unclear. Okay, so what do you all gather? LexiComp is Athens. So if you add both of those pieces of data together, what does this tell you about the drug interaction? Athens, how would you interpret that first paragraph? Athens?
It really caused less bleeding.
Yeah. We expected it to cause more, and they found it actually caused less, right? But of note, and we'll get to this in a second, that it was in the Taiwanese patient population, right? All right. So thank you for catching that. I almost missed that paragraph. Thank you. And we're going to move on to facts and comparisons. So facts and comparison puts it in the same type of section. So they put this information in the discussion section. And again, they talk about pharmacokinetics, same type of thing. They also talk about in a randomized open label crossover kinetic study. Again, you're looking at kinetics, but you also have some genotyping done. And then here, they talk about a 65-year-old male with history of restrictive obstructive lung disease. A few other things going on with him. He was taking Bactrim, he was taking rivaroxaban, he had recurrent DVTs, It was antiphospholipid body syndrome, and they initiated clarithromycin, and he was found to have some hemorrhaging, right? So now we have a patient case, but our patient in this case is significantly different from the one that we're talking about, right? This guy's probably much more higher risk with everything that he has going on. He has other risk factors that our patient may not, okay? And then it also goes on to talk about the package labeling for Xarelto, and that the increased risk of rivaroxaban can lead to bleeding risk, especially when it's administered with other agents that continue to increase its bleeding risk. It also talks about Canadian labeling and how we should use caution. All right, so again, when we look at our 3 different interaction checkers, we find very different information, where one only presented us with our pharmacokinetic information, one presented us with pharmacokinetic information and patients from a Taiwanese patient population who actually had the opposite of what we think our drug interaction will be. And then finally, we have our pharmacokinetic option, maybe some genetic information, which would be important to kind of bridge those two together, right? That maybe some of our populations are different risk genetically than others. And then we have this example of this very complicated man who had some complications, correct? So we see that there's a wide breadth of information that we get from each interaction checker, and it's important to look between all of the 3 to figure out what's really going on with our patient, right? Or what we want to do for our patient. Okay, so moving on to the last piece, which is going back to question 3, what are we going to do for our patient? So somebody in Augusta then, tell me, what do you want to do with this patient? And why? Augusta?
Just try it, Sarah.
He doesn't have bronchitis at all?
We could either go ahead and let him take the clarithromycin because it looks like the risk is pretty low, or just to be safe, we could try azithromycin, which doesn't come up as a drug interaction at all with rivaroxaban. It's also possible if he has a viral infection, it doesn't need an antibiotic.
Perfect, Augusta. Thank you. So we've got multiple options, right? We can go ahead and get it because maybe it's not such a big deal. We could switch to a different agent because there's no drug interaction at all. Or maybe we don't need drug therapy because maybe he's not sick, was the last one I heard, which is also fabulous. And I'm okay with either 3 of those options, actually. And then my last question is, how would your recommendation change if the patient was younger? And by that I wanted to get at renal function. And the way that we kind of think about that is this management piece. So on facts and comparison, they call it management. On LexiComp, they call it patient management. And then on Micromedics, they call it clinical management, okay? And all of these different resources kind of give us relatively the same, but maybe slightly different information. But this is typically where I go to, like, okay, I know the literature, I have my patient in my head. Is there any more information or tips or tricks that they could give me in this section that might help? And the one that I found to be the most helpful in this case was maybe LexiComp, because they talk about my differences in creatinine clearance here. And I know, based on the rest of the lecture, which we'll get to in a second, that renal function and rivaroxaban is important. So this patient has a decreased renal function, so maybe I'd probably switch to another agent, or I would convince my resident, this is a bad idea, let's just consider it a viral infection and watch him for a second. Okay, versus if it was a younger patient, and there wasn't any issues, I'd be like, yeah, just go ahead, his renal function's fabulous, don't worry about it. Okay?
Dr. Misher, I have a question in Athens. So on your 5th slide, you have listed the drug-drug interactions for P-glycoprotein, and azithromycin is listed right along with clarithromycin as an inhibitor. So would that mean that in this case, would you just avoid any macrolide antibiotic perhaps and suggest something different to the resident, or would you say the azithromycin is fine?
Let's look. So when we look at azithromycin and we look at rivaroxaban, it comes up as a B recommendation. I'm looking at Lexicomp, it's a B recommendation. If I go to Micromedics, I can type. If I look at Micromedics, it doesn't come up at all, right? So the level to which it utilizes PGP is different. So just because it's a PGP, or I think azithromycin also has a touch of 3A4 as well. So even though it goes through PGP, it might not go through PGP to the same degree that clarithromycin goes through PGP. I didn't look this up beforehand, so I'd have to read through all this to make sure, right? But my guess is that azithromycin doesn't go through PGP as much and 3A4 as much as clarithromycin, as much as we already talked about before, erythromycin, right? So the degree to which these enzymes are utilized and the pathway between the agents is different. Does that make sense? So yes, you could, but I would more use azithromycin over clarithromycin if it's applicable and susceptibilities are appropriate. Does that kind of make sense? Does that answer your question?
So I was wondering, would you suggest using a different class of antibiotics, or would you just go with the azithromycin?
I'd go with the azithromycin. The other right there. Say it again.
Thank you.
Yep. I would give the resident some confidence. Hey, yeah, that sounds like a great idea. Let's use that. But let's just switch the agent within the class that we're using. That's a good little pharmacist tactic. Because if you pick something that still works in the same class, I'm not Dr. Bland, so I don't know susceptibilities of acute bronchitis to azithromycin. That's not my area of specialty. But I would look it up and make sure that it covers. But as long as it covers, yeah, I would go with azithromycin if I was going to pick an agent. Just off the top. Is that going to make sense? All right, let's move on. The other thing that I want you guys to be aware of is drug-drug interactions when it comes to bleed risk. And this is obviously very similar because this is the exact same thing that we think through when we have warfarin therapy. So it's no different. NSAIDs, aspirin, antiplatelets, the G herbals all lead to increased bleeding risk. You can add SSRIs to this as well, but these are the ones that I typically think of in terms of bleed risk, and I commonly see in combination with DOACs for various reasons because of the overlap in disease states. Okay? All right, so if I'm going to quiz you on something, these are the ones I'm going to hold you to in terms of bleeding risk for DOAC. All right, let's move on to, and I kind of flip-flopped in here, so I'm sorry. When you look at the objectives and you look at the flow, I decided to change my flow at the last minute. So we're going to talk about drug-food interactions. And what I want to highlight with drug-food interactions is that rivaroxaban is dose-dependent when it comes to food interactions. Okay, so when you start to get to the 15 milligram dose, you're going to have to make sure that you take it with regard to food. Vitrixaban is with food, so we talked about vitrixaban a little bit. We're not going to highlight that a whole lot here, but also with food. And what I want to highlight is dabigatran. So dabigatran does not have specific recommendations when it comes to food interactions, but we do know that there is a delay in the Cmax of dabigatran when you take it with a high-fat meal. Okay, so it's not really recommended for, you won't see it necessarily as it comes up as a big issue, but typically with dabigatran, we try and avoid it with high-fat food.
For the rivaroxaban in your
side notes under the PowerPoint, it said greater than 10 milligrams take with food, but I think you just said 15.
10, sorry. 10, so, yes. When do I typically recommend? You can go at 10, that's fine. Let's go with 10. I think clinically I typically do 15, but 10. I think the actual package insert is 10. Scratch that, we'll do 10, just for fairy's sake, because I think that's what matches the package insert. All right, so let's run through patient case. All right, so patient case 2. I'm going to give you maybe like 5 minutes because we're running out of time. And it's only got a couple questions. So take 5 minutes, read through the case real quick. It's fairly straightforward. All right, we're gonna move forward. All right, so let's go back to the package insert for rivaroxaban. And I get this backwards because our information in the clinic, we do different for the package insert, so I always get it backwards. So let's just look at the package insert together. And we're just gonna highlight what the package insert says. So if we look at the package insert, with the 15 and 20 milligram dose, which is why I said 15, I caught myself. The 15 to 20 milligram dose in the package insert, it says should be taken with food. And then the 10 milligram tablet you can take without regard to food. And I always get this backwards every single time. In our patient information at the clinic, we have 10 in our patient information, and I think that's because they worry about patients switching from the 10 to 15 to 20 milligram dose. And I think they try and make it the Xarelto information universal across patients. So according to the package insert, I will not test you on this particular piece of information, but according to package insert, it's 10 to 20 milligrams. They actually have to take with food, but clinically, obviously, in my clinic, we do stuff different, and it's because it's hard to catch when patients switch doses or if they might need a different dose. Questions about that before I move forward? That's a clinical nuance that I'm not going to test you on a clinical nuance. I'm not about that. certainly if I give you a 20 milligram dose, I expect you to tell me to take it with food. But I'm not going to differentiate between a 10 to 15. But realize it is dose dependent. All right, so somebody in Albany, we're running out of time. So somebody in Albany, present patient case number 2 to me very quickly.
It's a 45-year-old Caucasian female presents to the pharmacy to refill her prescription. She has a McDonald's bag in her hand, and when you're conversating with her, you discover she has a past medical history for obesity and a DVT 2 weeks ago. She takes dabigatran, and in her McDonald's bag, she's eating a sausage, egg, and cheese biscuit with whole milk.
Good. So somebody in Augusta, tell me, what do you recommend regarding her dabigatran? What's your recommendation for the dabigatran? Augusta?
Should you like space it out? She's intimate.
Yeah, why doesn't she call them? She shouldn't take it with this particular meal because it has a high fat content. And so she should just take it at another time of day. She just shouldn't make it with a high fat meal because it will not absorb as well and she won't get the levels in her body that she needs.
Yeah. So not necessarily that it won't absorb as well, but it'll just have a delay in that absorption. So you're exactly right though. The recommendation is, hey, maybe we shouldn't have it with lots of high fat in this type of meal. Or at least separate it. Right? So maybe take your dabigatran and wait, or eat and then wait. Likely I would probably take the dabigatran first and then wait to eat what's in that bag of yours. Okay, or eat it with a snack if you want to eat a snack now and have that a little bit later for your meal. Don't eat all the fat with it necessarily. Okay? That was.
How long do you have to separate the half-fat meal and the medicine?
So unlike other situations where we have an exact 2 hours before, 4 hours after, we don't have that information for dabigatran. We don't know what the delay, what the absorption delay is, or how long you should wait for the absorption to be affected. But that's always my golden rule of thumb, 2 hours before, 4 hours after. Although I wouldn't quote that for this particular study because we don't really have the evidence to say that's a good recommendation. But in general, if you always have high-fat meals for breakfast, I would say take your dabigatran. If you want to eat a snack for breakfast and have a bigger breakfast later in the day, then do that. But just be careful with what you're doing. Same thing with dinner. So I made an example out of this because it's a relatively, you think of it being small, right? Or most patients would think of a sausage egg biscuit being relatively like small amount of food. Or at least that's what my diabetes patients tell me. But it actually is really high fat content for not that much food. Considerably. I mean, it's a lot of calories. The volume is not very much, but it still has a lot of high fat. And then whole milk obviously has a lot of fat in it. Okay, but most of the time this comes up with dinner as well, so thinking through dinner. And the last piece of this case was thinking through, okay, so if our patients were encouraging not to have high fat meals, and we usually think of high fat meals as being unhealthy, and we think of them typically being, sausage, egg, and cheese biscuits, that's not always. So sometimes we can have healthy foods that are high in fat. So what are some examples of healthy foods that are high in fat, have high fat content? Somebody in Savannah?
Avocado, yogurt, salmon, nuts.
Yeah, those are all perfect examples, right? Especially avocado, for some reason, people don't think of avocado being high fat, but it also has a high fat content. So sometimes we have to make sure, even with our quote-unquote healthy patients, that we're kind of helping them think through what is the fat content? Because fat is fat, right? So fat is going to change your absorption of your dabigatran and make that delay just as much as unhealthy food will be. Okay, so watch your counseling points when it comes to eating. I have quotation marks around air quote. You guys can't see it in the other campuses, but I'm air quoting healthy around this. All right, and the last concept I want to hit home for today is renal adjustments for DOAC. And as I mentioned in APP, I do not expect you to tell me the renal dosing for every DOAC every time. I don't know it. I look it up because I don't want to mess it up, especially when it comes to DOAC therapy. So renal adjustment is something that I look up every time for every patient because it is so variable between each DOAC. So when we look at our DOAC and we think about renal clearance of each of them, we have a huge spectrum when it comes to renal clearance. So all the way on one end of the spectrum is dabigatran. On the other end of the spectrum is apixaban. So dabigatran is largely renally cleared. So we depend on the kidneys a lot when it comes to dabigatran. So if I have a patient who has questionable renal function, that gives me a good excuse not to use dabigatran. Okay. Rivaroxaban is a little bit better than dabigatran, but still not that great, with about 66% renal. Edoxaban is getting better, but apixaban is the best when it comes to renal function. I do anticipate that on an exam, you will be able to quote to me that dabigatran is the worst, rivaroxaban is the next, edoxaban is the next, and apixaban is the best. So I would anticipate that you do very clearly are able to demonstrate to me that you know which of these agents and in which order renal clearance matters. Questions about that? All right. With that being said, let's do our last case. And let's do it together. Okay? So in our last case, NS is a 76-year-old African-American female. She presents to her cardiology appointment because she is newly diagnosed with atrial fibrillation. She also has arthritis and hypertension. She is currently taking ibuprofen and amlodipine. Her creatinine clearance is 31 mils per minute. And the cardiologist would like to start her on a DOAC. And so the cardiologist comes and discusses with you, what are my options for this patient? Which one do you prefer? So Athens, if you had to pick an agent for this patient with a creatinine clearance of 31 mils per minute, which agent would you pick?
Apixaban.
Fabulous. How would you figure out the dosing?
I think with this drug you have to take account weight when they're over 65, but just look it up on Lexicon.
Absolutely, I would look it up. That's always the answer. What is your dose and frequency? My answer is I'd look it up. Okay. What's nice about this exam for drug interactions is that part of it is open. So you will be able to look it up. Okay. So the answer is I would look it up. Very good. So I pick apixaban because this patient, you're mentioning it exactly. She's old, she's getting older, she's elderly, she's little, so her creatinine clearance probably isn't getting any better. It's only going to get worse from this point. Apixaban is my least renally active drug that I have to worry about, so I pick apixaban and I look it up. Okay? And is there another relevant drug interaction? Why haven't I put down as much? Savannah? Tell me about the other drug interaction with this patient.
I bet that's why we got 2 days to find it.
The ibuprofen increases the bleeding risk.
Yep. Ibuprofen increases our bleeding risk. So our little old lady who doesn't have good clearance of a renally active drug, we probably shouldn't have her on another agent that could potentially lead to bleeding as well. So we're going to probably going to be the ibuprofen, maybe acetaminophen, which is recommended in arthritis anyway. Okay? All right, guys. So, that's our patient. Isn't she cute? All right. So just to do a little summary of some things that we kind of talked about today, but some take-home points, is making sure that we educate our patients and providers. We do dose reductions and think about how the target drug is affected. So where we really become the main key holders in this is where we talk about those 3 different drug interaction checkers and the differences. So not just looking at an X and saying it's an X or a D and saying it's a D, but that we really provide education to our patients and our providers about what does that information mean, that we're looking for ways to change our drug interactions if it exists. We cannot come up with another option, we say that it's okay, or we initiate another drug. And key take-home point is that as pharmacists, this is our role. Understanding how those 3 drug interaction checkers work and being able to discuss the nuances of those 3 and the literature that's available is really what we do as pharmacists. So I will absolutely test you on how to use those 3 checkers and how do they play with each other. All right, so we are finished with DOACs for today. I will, first before we go, any questions about today's material? Okay, hearing nothing, we are together tomorrow. You have a quiz that is due before tomorrow's class. We are going to touch more on DOACs tomorrow in APP. And then I will see y'all then. Let me know if you have questions.
Erin, did you do that quiz?